Lynn Scheps. I'm the Vice President of Government Affairs at SRS. This is the second in our Ask the Experts webinar series. This particular one will focus on meaningful use, preparing for Stage 2. For information about future webinars, you can check the schedule and register at liveehrwebinars.com. I'll have a screen at the end with some resources that will have that link on it. So with that, we're going to get started. So today's webinar, as I said, is about meaningful use Stage 2. In the interest of time and, frankly, of not boring you with all of the specifics about every single measure, we're not going to go through measure by measure for each of the 23 measures. Instead, I'm going to highlight some important issues about Stage 2 and help you start to think about preparing yourself and preparing your practice. And we will talk about the details of measures that are particularly challenging and represent the greatest differences between Stage 1 and Stage 2. I will also talk about clinical quality measures, and there'll be plenty to cover in just this brief period of time. So I'm going to start talking about what happens in 2014, which is not necessarily synonymous with Stage 2. It depends on where you are in your time schedule. So everyone who's pursuing meaningful use will have to upgrade to a new version of their EHR, which will be called the 2014 edition, regardless of what stage you're at. It's a common misperception when people talk about certification that EHRs will be Stage 2 certified. In fact, certification is tied to the year, the calendar year, not the stage of meaningful use. It just so happens that for many people they will be starting Stage 2 in 2014. But everyone has to have 2014 certified EHR, and you can see they've changed the name of certification of the original certification from the 2011-2012 version to the 2011 edition in anticipation that there will be a 2014 edition that everyone will use beginning in 2014, again, regardless of what stage they are at. Because everyone will have to upgrade next year, CMS made some concessions regarding the reporting period for 2014. As you can see from this chart, everyone spends 2 years at each stage, and the earliest anyone will have to advance to Stage 2 is 2014. That's these medium orange color boxes. The only physicians who will be in Stage 2 in 2014 are those who began their meaningful use journey in 2011 and reported for 3 years at Stage 1, benefiting from the 1-year delay of Stage 2, or those who began in 2012 and reported Stage 1 for 2 years. But again, everyone will use the new software in 2014. And everyone in 2014 will be reporting for a 90-day period. This is the concession CMS made in addition to delaying the start of Stage 2. And they did this because they recognized that it would be too challenging to get all the physicians upgraded, trained on the new software, and used to the new reporting requirements by January 1st. So they've allowed everyone to report for 90 days in 2014. The only difference between these 90 days and the 90 days reported in everyone's first year of meaningful use, 2011, 12, or 13, is that in 2014, the 90 days are limited to a calendar quarter. So physicians must start their reporting period on January 1st, April 1st, July 1st, or October 1st. They can't start in any other months or in the middle of a month like they could in prior years. Now, there is one exception, and that is for those physicians who are first-time attesters in 2014, because they have to attest by October 1st to avoid the 2015 1% penalty they would incur if they weren't a meaningful user in 2014. So they can report any 90 days. You can see that here. I want to note that this 90-day reporting period for physicians beyond their first year of meaningful use is a one-time accommodation that applies only to 2014. If a physician advances to Stage 2 in 2015 or any time later than that, they're going to report the full calendar year even for their first year of Stage 2. So now that everyone knows when they will have to advance to Stage 2, let's look at the requirements, starting with the similarities between Stage 1 and Stage 2.
It's still a complex set of requirements. I would argue that it's somewhat more complicated than Stage 1. The structure of the program is still the core and menu structure that we've all come to know and love. And again, you'll be reporting on 20 measures structured differently, 17 core that you will report on out of the 17, and you'll choose 3 of the 6. One difference actually is that while exclusions will still count, exclusions that you can claim for not being relevant, they count as core measures, but if you exclude a menu measure, unlike in Stage 1, exclusions do not count, and they'll have to find a different 3, if you can, that you can report on in Stage 2. Again, primarily, everyone will be reporting by attestation and reporting on all patients. The reason that these have asterisks after them is that clinical quality measure reporting will be different. Clinical quality measure reporting for anyone who's beyond their first year of meaningful use, which means anyone in Stage 2, will be electronically submitted to CMS. And we're going to talk about the patients that you report on when we get to the quality measure, so I'm going to hold off on that for the moment. Once again, the incentives are all or nothing. So if you miss one measure by 0.1%, then you have missed meaningful use for the year, all or nothing.
And of course, you will again report on clinical quality measures.
So this is where the similarities to Stage 1 end. Now let's talk about how it's different. And the most significant shift in the focus of Stage 2 as compared to Stage 1 are in 2 areas: the intensified requirements regarding interoperability and the importance of patient engagement. So if we look at exchange, there is a measure from Stage 1 that's being eliminated in 2013, and that is that you no longer have to test the capability to exchange information. But it's being replaced in Stage 2 with a much more robust requirement which demands ongoing exchange of clinical information with other providers, with registries, and actually also with patients. The second major difference is that the patient engagement becomes a very important focus, getting your patients involved in their own care, responsible for their own care. And that's really where the patient portal comes into play, because everyone will have to have a patient portal through which their patients can access their information, their clinical information, and communicate with the providers. So I want to look at those measures first. So if we start with data sharing, because it's going to be a real change in workflow and in practice, if we start with data sharing physician to physician, providing a summary of care record after a patient has been seen by a physician as being either referred back to the primary care physician if you're a specialist, or referred on to a specialist or a hospital if you're a primary care physician, you will have to send a summary of care record. Now, this was a menu measure in Stage 1, and I will tell you that most physicians chose not to report on it because it was complex and a challenging workflow, but it was a measure. But it gets much more complicated in Stage 2. It's now a 3-part requirement, and it applies to any patients who are transitioned to another provider or another setting of care. So I'm going to go through the 3 parts. The first one is very similar to Stage 1. You have to provide a summary of care for over 50% of the patients that are transitioned, and you can deliver that to the other provider in any number of ways. You can print it out, you can send it by snail mail, you can fax it, you can hand it to the patient if you think they're responsible enough to deliver it to the physician. You have a lot of options for providing it for the first part of the measure. The second part of the measure is really the newest part, and that is that for 10% of your transitions, you need to transmit that information electronically to the other provider. And the third part, and this got a lot of conversation, stimulated a lot of conversation when the comment period was open to the proposed rule for Stage 2, and this is the way it was settled. You need to send at least one transition, not 1%, but one transition of care. The summary of care has to be sent to a recipient with an EHR from a different vendor. So in our case, our clients who have SRS cannot meet this third part of the measure by sending it to another physician who also has SRS. They have to send it to someone else with a different EHR. Now this, you can imagine, the workflow behind this is rather complicated because now the physician has to call up the physician that he's sending the information to and say, by the way, I hope you're not an SRS user because I need to send you a summary of care document and I need to find somebody who's not using my software. So CMS heard that loud and clear and they said, okay, we will also set up a test EHR that you can send one transition of care, summary of care record to, and that will count. So you have two options in order to meet that measure. So now let's look at the patient engagement measures. And again, as I mentioned, this has to do with the portal. And there are two and maybe even three measures that you could use the portal to meet. The first one is providing online access to health information and to your patients now. And this really replaces the measure, the two measures that in stage one also a lot of physicians chose not to report, and that was providing electronic access to patients who requested it, and hardly anyone requested it, and providing timely access electronically. So you're going to meet this by the patient portal. Now, the good thing about the patient portal is that you can now deliver your clinical summaries, the after-visit summaries that you give to patients when they're leaving after having seen the physician. You can post that to the portal, and it saves you the problem of printing it out and asking the patients, do they want it, do they not want it, and giving it to the patient, and some of them would throw it out, and you'd find it in the trash. And the portal can be used in a number of ways, but the actual online access to health information requirement is, again, a two-part requirement. You can see already how stage two is more complicated. The first is that 50% of the patients who have been seen by the provider have online access to their health information within 4 days. So let's take this in two parts. The having access means that you have given 50% of the patients who you've seen at least a slip of paper, something that says, here is our portal, here's how you log on, and here is your password, or here's how to set up your password. Once you have given them that information, you have provided them with access. Whether they use it, go to your portal, throw it in the garbage, or never look at it or can't figure out how to use it is not your problem. Your obligation is to give them access, provide them with the possibility of using the portal. Your obligation here is to make sure that the information that's required is actually available on the portal within 4 days, 4 business days. The second part of this requirement, and again, this was one that generated a huge conversation and many objections from providers and their professional organizations, 5% of your patients actually do have to use the portal in some way. And you'll hear this acronym, VDT. You'll hear this measure referred to as VDT. In fact, this whole measure is typically referred that way because this is the most troublesome part. And it stands for view, download, or transmit. So 5% of your patients actually have to log on to the portal and view their information. That would be sufficient. They can download it if they want, print it, send it somewhere else, or they can send it to someone else. So that's going to be challenging, and I can tell you and predict that people are going to be very creative. I've already heard of practices that have said, well, let's see, how can we get our patients to do this when we're not in control of them? Well, we could offer a $100 gift card through a drawing for everyone who logs on this month. Or we could put a kiosk in the waiting room and have one of our staff show the patients how to log on and actually log them in and set their account up. So it's up to your creativity. I welcome all suggestions. I'd be very interested in what people do, but that's going to be a challenge because as the physicians say, I have no control over what my patients do. It's enough that I get them to fill the prescriptions I give them. The government is very wedded to that particular measure, and when they were hounded and begged to drop the percent from 10% to 5%, but they would not eliminate it. So that brings me to the second part, the second measure related to patient engagement, and that is secure messaging, that 5% of the patients must send a message to the physician. Easier for the physicians to be the originator of the message rather than the recipient in terms of controlling compliance. But actually 5% of the patients must send a secure message to the physician. And they can use the portal. They actually can also send it via secure email, but I think you'll find that the patients are going to use the portal to send messages, and that will be a good way to get them to actually use the portal as well. So now I want to zoom back out and look at, now that we've looked at the particularly challenging measures, and just look at stage 2 to compare to stage 1 from kind of a broader perspective. One of the things that's going to be challenging about stage 2 is that a number of measures were removed from stage 2, and part of this, I perceive this as kind of a game. CMS and ONC wanted to keep the number of measures that meaningful users have to report to 20, and they wanted to add a lot of new measures. So they had to do some rearranging. So let me show you, for example, just watch carefully. This is the pinnacle of my PowerPoint capabilities, so I hope you appreciate this. But if you look at the measures, look at drug-to-drug and drug-to-allergy checks. You can see that this was a stage 1 requirement that does not appear in stage 2. However, it is buried within clinical decision support. And when we look at the clinical decision support rule, you'll see that it includes doing drug-to-drug and drug-to-allergy checks. Similarly, problem list, medication list, and medication allergy list, which were 3 of the reporting measures in stage 1, are no longer in stage 2. You can see that you're not going to be reporting on those, but they will be part of clinical summaries, a required part of clinical summaries. They'll also be a required part of the patient care summary that one physician sends to another physician. The challenge here is that since physicians are no longer reporting on those individual measures, it's going to be a little bit harder to keep track and monitor their performance and make sure everyone is doing what they have to do in order to meet all the other measures. So that's something for you to keep in mind. Clinical quality measures was removed as a core meaningful use measure, to drop the numbers again, but it appears as a completely separate category. So now we have core measures, we have menu measures, and we have clinical quality measures. Electronic copy of health information and timely access I talked about already, and those disappear as individual measures in stage 1, but they appear as the online access and VDT, view, download, and transmit measure. So you can see that even though there are many fewer measures, really nothing has gone away, and the work required has increased. Some of the stage 1 measures remain as stage 2 measures, but their thresholds may increase, or they may have more components, as I showed you already, but I'll show you some of the others. Oh, here's one more. I'm sorry. Drug formulary checks is now part of e-prescribing, a required part of e-prescribing. So now let's look at the measures I just mentioned that were stage 1 measures that you're familiar with, and just see how they've changed in stage 2. And you'll notice some of these were core, and at the bottom some of them were menu measures. We'll talk about that change in a minute as well. But CPOE is a major change, because in stage 1 it was limited to medication orders. Now in stage 2, not only has the threshold increased to 60% for medication orders, still based on permissible non-controlled substances, but now CPOE also applies to 30% of lab orders and radiology orders as well. E-prescribing, the threshold has gone up, and as I mentioned in the slide before, you also have to compare it to a formulary, which was a measure in stage 1, but you reported it separately. The recording measures, demographics, vital smoking status, are all going up to 80%, which should not be much of a challenge, because if you look at the results from stage 1, pretty much everyone far surpassed the 50% mark on those measures anyway. Clinical decision support rules are going from 1 to 5. They're now called interventions, and the major difference there is that they have to be related to 4 clinical quality measures on which you're reporting, and they have to get some information from outside of your system. Clinical summaries, still 50%, but it's been moved up to 1 day. But again, that's the one you can now post on the portal instead of printing out and mailing, or printing out and handing to the patient when they leave. Lab results, incorporating lab results, which was a menu measure, has gone from 40 to 55%. Patient reminders, the percentage has dropped, but the population is different. The population on which it's based is different. And I'm already thinking, since we have so many orthopedists and specialists, this is going to be a challenge for the specialists who provide episodic care, where you may have seen a patient twice for a particular problem. You've treated it, you've released them, sent them back to their primary care physician, and you have no reason to recall them. Anyway, let's look quickly at the menu measures. If you look, these were the 10 menu measures in stage 1. And they are all not going to be menu measures in stage 2, with the exception of syndromic surveillance, but they are all reappearing as core measures in stage 2, which means that they're required, that you'll have to report, you can claim an exclusion. What this means for you is that the measures from this list that you chose not to report on in stage 1 for whatever reason, you thought they were too difficult, you didn't understand them, whatever, you now have to report on as a required measure in stage 2. Now we have a big hole in the menu measure section. So those menu measures were replaced with a whole new set of measures. Again, syndromic surveillance is still here. That's why it's not bold. But here are the 5 new menu measures, and I'll go through them pretty quickly. Electronic notes for 30% of the patients that are seen. There has to be a text searchable progress note, at least one in their chart. The whole note does not have to be searchable. You do not have to be able to search for things between patients or between notes, but you have to have at least some part of the note that can be searchable. The rest of the note can be any other format, can have drawings, can be handwritten, but at least part of it has to be searchable. For physicians who order tests that return their result as an image, they need to be accessible through the EHR, either the image or at least a link to the information. I won't read you the exclusions, but you can see that there are some exclusions for some of these. Family history is a very important new one. It should not be too hard depending on how your software is configured, but for 20% of the patients that are seen, they have to have at least one structured data entry for at least one first-degree relative. Then there are the 2 registry measures. Now, a lot of you are going to exclude these because either you don't diagnose or treat cancer, or there's no agency that's able to electronically accept the information using the standards that your EHRs are all going to be certified for. And then there are specialized registries. And either, if you don't treat any diseases that are associated with a specialized registry, or there's no registry as noted here, then you're going to exclude those. But again, you will have to pick 3 of these 6, and unless you can exclude more than 3, you need to pick 3 that you actually can report with information. So I know I'm rushing because I want to get through everything and give you a few minutes to ask questions, but the last change I just want to talk to you is clinical quality measure reporting. The good news here is that beginning in 2014, the various government programs that involve reporting clinical quality measures are being harmonized. And harmonized means that you'll be able to report once and have it count for various programs in which you're involved. This was a major complaint because people were being asked to report on quality measures on pretty much the same clinical quality measures, but on different patients, different populations, different reporting periods, and different methods of reporting in the past. So in 2014, you'll be able to report once on the same 9 clinical quality measures selected out of a set or depending on your EHR, perhaps a slightly modified subset of 64 possible measures. You will have to make sure that the 9 that you choose will cover at least 3 domains. The CMS has set up 6 domains where they've categorized each of the quality measures into one of the domains, and they're things like cost savings, effectiveness.
I'm going to conclude this presentation with a summary of what I see as the major challenges posed by Stage 2, and then I'll offer some suggestions for how to address these challenges.
So let me quickly run down the challenges. First, as I think I mentioned, the emphasis on Stage 2 is on new measures and measures that had the lowest performance and the highest exclusion rates because they were so challenging in Stage 1. That you will incur some additional costs for things like portals, interfaces to labs, and communicating with registries. All EHRs are all vendors are going to charge. They may charge slightly differently and for different configurations, but you will, don't be surprised if you see some charges. We talked about patient engagement and shifting the responsibility to patients, but having physicians be responsible for the actions of their patients. We also talked about having to track your compliance on requirements that are no longer standalone measures, so may not appear on your AMC reports, your automated measure calculation reports. That's going to be a workflow and a management monitoring challenge. Clearly there can be an impact on productivity, and that will vary depending on your EHR and how efficient it lets your physicians input the information. And of course, as the requirements are increasing, your costs are increasing, the incentives are diminishing. Most of you will be at either $8,000 or $4,000 when you get to your first year of stage 2.
So here are a few things you can do now to prepare for stage 2. You don't have to wait until 2014 to get started.
To make sure that you've got your stage 1 workflows solidified and in place. Wherever possible, try to shift your tasks from the physicians to your clinical and administrative staff. Look carefully at your EHR and the effect on productivity and how well they're helping you meet meaningful use. Patient portal, if you have a portal, start getting your patients comfortable using it. If you don't have one yet, start to look at it or see what your EHR is going to offer you and plan on changing your workflow to provide the clinical summary by putting it on the portal. Avail yourself, as you did today, of every opportunity that's presented to you. CMS actually did a very good job in stage 2 of offering a lot of webinars. Their website has a lot more materials. They call them tip sheets. Go look to your vendor and see what they're offering. I hope those of you who don't have an EHR yet will consider SRS. I can tell you that we offer a tremendous amount of training on meaningful use, including our user summit, Meaningful Use University. We have these webinars. We have webinars for our own clients as well that talk more specifically about meaningful use and our software. And don't leave, even though you only have to report for a quarter in 2014, my advice is don't leave it for the last quarter, because if you miss anything at that point, you have no wiggle room. You can't try again. You can't move it forward or backwards a few days because you're limited to the calendar quarter. I just want to thank you all for attending. Feel free to give me a call if you have any questions, or send me an email. My phone number and address are there. As I said, the CMS website has some really good tip sheets and measure specification sheets that will help you possibly answer some questions that you didn't think to ask now or that come up as you're implementing and thinking about it. The Information Center is always available to answer your questions. And feel free to avail yourself of our website. We have a multi-page, maybe 10 or 12 pages on meaningful use, where we've tried to distill down what is presented in volumes on the CMS website to more readable format, although again they did a much better job in stage 2 of making their information user-friendly. Still a complicated program, and there's nothing you can do about that, but at least the information is all there in a handy format. But thank you all for joining us, and I look forward to talking to you if you have any questions or we can help you in any way.